Welcome all of you to this session on TB spine as part of the infection course, musculoskeletal infection. And TB spine is, a very, very important topic. I think if you practice in India, there is no way you can escape it, no matter at what level you practice. And you should be able to analyze, investigate, plan a management, and at some stage, if you need help, you should know when to seek help and from whom to seek help. So I think TB spine is one topic which you cannot escape if you're practicing in India. There was a time 20 years ago when we thought that we are seeing the end of it, but there has been a resurgence, and I see as many cases today as we used to ever see in the past. I have 2 hours to try and take you through the entire gamut, which is not easy in both ways. One is because 2 hours is too short. It may take 2 months to tell you a lot about TB spine. On the other hand, 2 hours is a long time to keep you engaged into one topic. So we'll just try to keep it interactive and simple. Just to kick off, to get some thought process, this is a 32-year-old male who presented with neck pain, torticollis, and these kind of swellings. He also had stiffness in the neck and dysphagia, and he had this warm fluctuant swelling. The neck movements were very painful, tenderness. He had, in neurology, he was normal. He was walking. He had a very little grip weakness, hyperreflexia, and the power was absolutely normal. So this you can see is his clinical picture. This is his X-ray. Can anyone point out what we are seeing in the X-ray? Any one person unmute and tell me fast.
So there is an increase in prevertebral soft tissue shadow.
Yes, very good, Aisha. That is very well done. So I think one of the important lessons at looking at X-rays is look at the soft tissues, because we only tend to look at the bones. And somebody who's not used to looking at soft tissues may completely miss this. And what we see here is this huge increase of the prevertebral soft tissue. Now, of course, in this patient, we have seen him clinically as well. But suppose this comes as just an X-ray to you, you know what to look for. So then obviously we got an MRI done. And because we'll go the algorithm later on, but just to complete this case, we got an MRI done, which is clearly showing sort of huge abscess. And we are seeing this sort of destruction in the vertebral bodies. And we are seeing this sort of cord compression over here, right? And as you can see, there is a lot of cord compression over here. Now, the question now here is, he's got this massive abscess, which you can see coming out in the chest, and this kind of cord compression. Now, the question here is that, what do you do with this patient? So, so who would do surgery for this? Like, would you do surgery for this? Who would operate this patient? Anyone unmute your mic and talk.
Sir, since it's in the upper cervical spine and the lower cervical spine, and likely there is likelihood of compression to the airway and esophagus, that this is itself an indication for operative procedure.
So basically, one is thinking of a surgery for this at this stage, and this would be sort of one of the thoughts which people have. And just to sort of take you all through this, this is the post-treatment MRI. Just to show you, this is the post-treatment MRI after 6 months of treatment. And this patient was treated only medically, not surgically. And you see at 4 months, the abscess has completely gone and the movements are normal. And this patient was treated medically, not surgically. So this is a small lesson to you all about, in what way TB behaves. And now what we'll do is I will take you through a presentation. So this 17-year-old female came with a mid-back pain since 8 months, no tenderness and neurology okay. And again, this is the X-ray. Honestly, not very much to see in this X-ray, but I'm sure our young lady would pick up the fact that there is a little increased soft tissue at the side. Disc space, if one really is finicky, one may say that one of the disc spaces is narrow. The question is, what next? You can see here as well, there is a little sort of abscess over here. And the next would be an MRI. I think in modern practice, I don't want to get into the details of it, but any patient who have a suspicion, you are quite justified in getting an MRI for these patients. And the MRI as well, you can see there are these three important images which you see. We are all used to seeing T2 first, because T2 is usually the most, and you can see there is a sort of a signal change over here. And if you look at T1 as well, there is a marrow edema. So there is a marrow replacing lesion over here. There's marrow edema. And the stir image, which suppresses the fat actually, shows the brightest signal, because this is the one where any inflammation other than fat will be shown up well. So obviously there is something here. And now if you look at the axials, you can see that there is a sort of a lesion. And you can see that this is a small sort of soft tissue abscess over here. Dr. Akash, are you able to see my arrow as well?
Yes, sir, we can.
Arrow as well, yeah.
Yes,
right?
we can.
Yeah. So now the question is, what do we do for this patient? Like, what investigation we do? So obviously here we have a patient who's come with a history of pain, who's got a lesion on the spine, which we now need to investigate. So very basic is going to be your CBC, ESR, CRP. I love ESR. It is 40 rupees. Used to be. I must be 100 rupees now. But it really gives you a good idea. It's absolutely not specific for anything. But even the sensitivity isn't great. But it is a value for money. Because if the ESR is raised, you immediately, your antenna go up and you need to do this. We are thinking TB. This lecture is on TB spine, and this is India, and TB is very common. So then there is the Mantoux test. So this is an interactive session, but it's very difficult for me to do interactive now online because all of you are in different places. But who would do a Mantoux test? Anyone other than Ayesha? Can someone tell me? One of the delegates? Anyone other than? If otherwise, I will call out because I have not been introduced to you also. Srinivas?
Sir, we do. Sir, we do Mantoux test.
Okay. Dr. Durgesh?
Yes, sir. Sure. We do the Mantoux, sir.
Okay. And if you do the Mantoux, why would you do the Mantoux?
Sir, just to get an screening test, as a screening test.
Okay. Fine. So we will leave that for the time being. People seem to. Is there anyone who won't do a Mantoux among the delegates? Anyone who will not do a Mantoux, who will not ask for a Mantoux? Okay. So let's go ahead. What about IgG, IgM, the so-called TB gold test or immunological serological testing? Anybody? What do you feel? Nand Kishore? Dr. Upadhyay? Anyone can answer this question for me? Angad? Who would do an IgG, IgM? Is there anyone who won't do
No,
IgG,
sir.
IgM, TB gold lab test?
I think Srinivas has
Sir, we do,
unmuted.
sir. Sir, we do, sir. Generally, IgG,
Okay.
IgM.
Okay. So I will come to that also in a minute. And any other test? Would anybody think what other tests would you do at this stage?
So city-guided biopsy and gene
And
expert. Gene expert.
gene expert. Okay. So that is a gene expert of the CT guided biopsy, right?
Yes, sir.
Okay, fine. So see, this is actually the image which you see, and these are the various tests. These are the various plans you can do. One is wait and watch, but I think that is not a good plan because this patient definitely has a lesion. The other one is so-called anti-TB medication or empirical AKT, which would have its pros and cons. Any other test? There are some other tests like if the patient is very affording PET CT, but again they don't really give an answer. And finally, we come to biopsy. And I think biopsy is absolutely essential here. And you can have these biopsies done in three different ways. You can either do a C-arm or fluoroscopy guided, which the surgeon does himself in the operation theater. In this, you get a biplanar imaging. You can get AP lateral and you can put in the needle and take it. Or you can do a CT guided biopsy, which typically is done by interventional radiologists. Or lastly, a surgical or an open biopsy is another option. So with this sort of a lesion, what we sent her for is a CT guided biopsy. So CT guided biopsy goes in and tries to get a chunk of bone and soft tissue. We usually wide bore needles are put in, like a true cut needle or a Jamshidi thick needle. 11 bore to get a chunk of tissue, and then these are sent for all of this. So it is very important that you send it for all of these. So histopathology is very, very important, because very often the diagnosis comes on histology. TB cultures. Now you've had lectures before. I am not sure whether they covered the microbiology, but growing TB from musculoskeletal samples is not easy, because it is possibacillary disease, and therefore they have to use something to amplify the result, and that is known previously as BACTEC and now as MGIT, and this should have been covered by now. If not, you take my word for it that you have to send it for TB BACTEC stroke MGIT. You
Yes,
also
we had covered, but then you can tell them again, no problem.
Yes. You have to also send it for aerobic and anaerobic cultures, because one of the differential diagnoses for this is a non-tuberculous infection, which is very common, which I will tell you about. Even fungal culture, so if you're doing a biopsy, you should send it for everything. And last but not the least, what was pointed out is the gene expert and LPA. And now there is another test which has come, which is even more sensitive, where they do a genetic test. Now the gene expert, the value, I think there'll be a slide later on, but I will just tell you because it was mentioned before. The gene expert, the biggest value is that the report comes in first 48 hours. Everything else will come later. Histology will come in 7 to 10 days, depending on if they have to decalcify the lesion. Your cultures may come at 3 weeks, 6 weeks or later. And your smear may come earlier. But finally, the gene expert comes in 48 hours. It gives you information about two things. One is whether MTB is detected or not. And if detected, whether it has rifampicin resistance or not. I may have a slide later, but in that case, I will repeat it. But why is rifampicin resistance is very, very important? Because if a sample is known as is rifampicin resistant, it is also taken as a surrogate marker for INH resistance. And that is to be considered as MDR-TB. So these two things can be found out just by this gene expert. So this patient had the biopsy was not detected, but it was detected finally on the LPA. So here it was detected, it was susceptible to rifampicin and INH, and the biopsy as well showed a granulomatous inflammation. So if the histologist sees granulomas and caseative necrosis, that is a very, very good indicator of it being TB. And what is important is the culture, and once the culture is positive, you have to do the sensitivity testing for the drugs. And for instance, this one was sensitive to the primary line of AKT. So the question of doing the biopsy is for multiple reasons. I think one of them is to prove your diagnosis, to establish your diagnosis, and so that you don't have a mistaken diagnosis. It can be anything else, which I'll come to later on. And the second issue is that it being TB, also it has to, we have to make sure that it is sensitive to these drugs. So that is important. Just give me 1 second. Just give me 1 second. Now, the sensitivity can be to these 4 drugs or to a larger panel. It depends on what your hospital does. It can be a 12 drug sensitivity as well, depending on the clinical picture, and you have to look at the cost as well. But the sensitivity is extremely important. Let's look at this other patient. She's a 25-year-old female with upper back and right scapular region pain for 3 months, imbalance of gait, difficulty in walking, and weakness of both lower limbs for 8 days. And she took Visalon, so it slightly improved, but still she was weak in the legs. On examination, she had myelopathic gait. That means she needs support to walk. She had hypertonia in both the legs, and the power was 3 to 4 with a sensory level and exaggerated reflexes. So this is the X-ray. Now in this patient, there is not much. See, on the X-ray also you can see, because you can see soft tissue shadow, and you can see here there is a kyphosis and a destruction. But what is important is that this patient who's come with a neurological condition is much different from the previous patient who has come with only pain. There's a huge difference in what we had to do for this patient versus what we had to do for that patient. And for this patient, we would do an MRI straight away. One would not waste time in doing anything else. And this is what the MRI is showing. So the MRI is showing destruction of this vertebra. It is showing cord compression, and it is showing cord signal change. You can see the signal change in the cord. So this is a very important issue. And here you can see the MRI. So at this stage, I just want to ask how many of you would operate this patient straight away? So the power is grade 3 to 4, myelopathic, but not very bad. Like patient is able to stand and walk. And this is the MRI picture. Firstly, does anyone have anything to say about this MRI picture, which is something which is maybe a little unusual? Anyone? Okay, because if I'm okay to talk all the time, but so I will just tell you what is different in this MRI compared to other MRIs. So here, if you see, these elements are also involved. Can you see this? These are the posterior elements. This is the pedicle. Okay, this is the lamina. So all of this is also involved. The other thing is that this is iso-intense. Iso-intense means it is not hyper-intense. So these are few things which, a little raise the eyebrow that there's something different going on here. Now for this patient, would you do a biopsy? Would you start him on AKT, or would you do surgery for this patient? So Ayesha, surgery for this patient?
Sir, prior to that, I think because she is in grade 4 motor power, I think we would like to go for further investigations, because that pattern also does not mimic tuberculosis per se. So I would want to do some further investigations before going for surgery.
Yes, so that's a very good answer. Firstly, that in terms of hurry, it is not extreme hurry. Because this patient is still having power. This patient is now under your care. It's in the hospital. So, and this thing looks slightly different. So doing medical management or AKT for this patient is out of the question. You either decide on biopsy versus surgery, depending on how bad the neurology is. So in this case, I'll tell you what we did. We did the biopsy, and the biopsy showed a round cell tumor. So that round cell tumor was a myeloma or a plasmacytoma. So this was not TB at all. What's important for you to know is that every lesion isn't TB. Okay, that is lesson number 1 from this patient. We treated her with steroids and radiation acutely, and then chemo, and this patient had a full recovery without surgery. So Cox spine is a great mimic. The presentation may be variable. It has a very long insidious course, and many of these patients, they may be mistaken for non-specific low back pain. And some patients come with acute presentations. The early imaging is confusing. So when I told you do MRIs, but what happens is sometimes if we do MRI too early also, it is very confusing, because a lot of changes such as modic changes, degenerative changes, end plate fractures, they tend to confuse you, especially in the stir images. And the imaging findings are a variety. It's a wide variety. Like even for the last patient, although the pedicle was involved and there was iso-intense, it would not have been a huge surprise to me if that had turned out to be TB as well, because TB actually mimics everything. So now TB is 1% of all cases of TB are actually Cox spine, and 15% of extrapulmonary cases. And the biggest problem is the delay in diagnosis. And the average time of presentation in one paper from Japan said that it was 1 year and 7 months, because it's a very slow kind of progression. And this article from India, actually from Ganga Hospital, said that only 25% patients present within the first 3 months of symptoms. And therefore, early diagnosis and treatment is crucial. And why is it crucial? Because we want to not only treat the disease, but we want to prevent the sequelae and the complications. We want to prevent deformity. We want to prevent neurological complications. And that is why we want to try and treat them medically rather than surgically. So if you look at this patient with just a small disc space narrowing, this patient came to us at the second stage where the middle X-ray is there. But when we pulled out her old X-ray, this X-ray was also seen, at which stage it was not diagnosed. And if we had done an X-ray at that time, if we had done an MRI at that time, we could have spared this patient, because this patient then went on to have further destruction and came to us and then needed surgery. So early diagnosis is the difference between conservative versus surgery. Even if the patient has surgery, it is a lesser magnitude of surgery versus a larger magnitude of surgery. Deformity also, if the patient comes in late, deformity is an issue. Neurological deficit. Now what happens is that, yes, we all know that in TB spine, when you operate, the neurological deficit recovers. There is no doubt about it. But the patient always has some of the other problems. Like when a patient has cord compression and even they recover, they have a little spasticity, little incoordination. They are not normal. So I think it's very important for us to prevent this neurological deficit. And pain and suffering, of course, is one more thing. So if we look at these patients, they present depending on the site and stage of they come with back pain. So back pain would be by far the commonest symptom, but again, it's only 70%. That means that 30% don't have back pain, right? Fever also is not very constant. So 30% have weight loss. So the what we are taught in PG, that constitutional symptoms, they are not invariable anymore. Some patients present with neurology and some patients present with night pains. Now, what is the problem with back pain? Our clinics are flooded with back pains. Like, especially as a spine surgeon, all my patients come with back pain. But even for a general orthopedic clinic, 50% patients come back pain. And sadly, most of them are actually non-specific back pains. I mean, they are degenerative pains, postural pains, psychosomatic, etc. But out of those 50 back pains which come to you, to separate the specific one becomes a challenge. And for that, you need something known as a red flag. In your, what raises your attention is a red flag. So if there is pain which is unrelated to movement or posture, if there are systemic or constitutional symptoms, age less than 20 or more than 55, or neurologic symptoms. So the first one is the most important. I think I listen very carefully to the patient when they're talking about the type of pain. So any patient who has pain at rest as well is a patient you need to worry about. Any patient who's woken up in the middle of the night with pain is a patient you need to worry about. Patients who do everything, walking around, and those who have pain on movement, they are less worrisome. And the other issue is the duration. I mean, if a patient says, I've had 5 years of pain, it's very less likely that they would have had TB for 5 years. And if a patient comes to you with 3 days of pain, again, I mean, they may have, but it may not be also. So it's these subacute cases, the 3 to 6 weeks of pain, this insidious onset pains, patient not getting better, patient getting night pain, rest pain. These are the ones who you need to investigate. So my red flag is the duration of pain, night pain or mechanical pain, socioeconomic scenario to some extent. On physical examine, if they have spasm and tenderness, yes, and if they have other risk factors as well, whether they have diabetes, immunocompromise, etc. So constitutional symptoms, fever, loss of appetite, and weight loss are often not seen. I mean, in today's era, we are seeing even very wealthy and high-class patients getting TB spine, and they don't have these sort of symptoms. So it's not necessary. I mean, yes, 30% have them, but not all. In the elderly, again, there is a problem because in the elderly, the constitutional symptoms are even less, and it's very difficult to diagnose TB spine in the elderly. Diagnosing it becomes very important. Now, coming to the diagnosis and the investigations, we just had a little introduction, but I didn't go into details because the details is something quite different. Now, CBC, ESR, CRP is my favorite test, like I told you. Mantoux and immunological testing. So these are not done anymore. So the tuberculin test or the Mantoux test, I'm very sorry to disappoint all the delegates who are very keen on the Mantoux test. It has no value whatsoever in India, especially in adults. The reason is that in India, everybody is exposed to TB. Everybody is primarily exposed. So everybody will likely to have a positive Mantoux test. So there is really no advantage of doing a Mantoux test. If the patient has immune compromise, actually you get a false negative. There is no value in doing the Mantoux test. Regarding serological testing, that is IgG, IgM, which is sold as TB Gold. This has now been shown to be completely unreliable, especially in India, where everyone is exposed. And it was thought to be by test for latent TB, but it has led to huge errors in management because people do these tests and then give AKT to a patient who doesn't have TB. And in fact, it has now been banned by the Indian government in 2012. I don't know, it is still available in labs, but the government himself has banned and warned against it. What about imaging? So plain X-ray is the first thing which any orthopedic surgeon does. But for the lesion to be visible on a plain X-ray, there has to be at least 30% loss of bone, which may not be, because a lot of our patients in India do. So, I mean, practicing in India is a huge, complex variety of patients. You have patients who come really very early also, and you have patients who come very late. But those who come very early, the X-rays may likely be normal for up to 3 months. And as we've seen in the first case, looking at the soft tissues becomes imperative, because that gives you huge clues as to what is happening. So this patient is another patient where if you look at the X-ray, it's very subtle, but you can see that there is a little, this disc is not good, but it depends on the quality of the X-ray. But what you can see is the abscess. This is another one where you can clearly see the destruction, but again, the abscess is another thing which you can look at. This is another patient where you may just miss. I mean, many orthopedic surgeons would cast this as a normal X-ray, but in addition to a prevertebral shadow here, this patient also has an atlantoaxial dislocation. So the thing is, if you're not used to seeing these X-rays, you're going to miss these sort of things. So you can see there's a huge prevertebral abscess over there. This is another one where very subtle. I mean, you may just miss this in the OPD. There's hardly anything to be seen. This disc is a little narrower than this. This disc is a little kyphotic compared to this, but this can easily be degenerative. But what you can see is these are the psoas abscesses, and you can see these huge increased lines of the bulky psoas. And this patient again had TB. So this is the psoas abscess, which you see as a shadow on the X-ray. Another one is the first case which we saw. These huge abscesses are seen in the X-ray. So now the MRI has now become a gold standard in the diagnosis or the diagnosis of suspicion. And what we look at the end plate. Usually it's a paravertebral lesion, paradiscal lesion. It is usually anterior, and there is subligamentous spread. And you can see abscess formation, and you can see calcification in the abscesses, which sort of take you in the direction of a diagnosis of TB. MRI is very, very essential for the early diagnosis. And as you can see, if you look at TB, 15% in plain radiography. Of course, there are different papers, but 100% you can diagnose it on the MRI or even in the CT. CT gives you a very good visualization of the bony details. So you can see lytic lesions, you can see sclerosis, you can see disc collapse. But CT will not show you the soft tissues so well. So cord compression, epidural extension, abscesses, they are not so well seen with CT. So given a choice, an MRI is by far the best investigation. So the only issue is the downsides of the MRI. So the findings can sometimes be non-specific, and like a degenerative or a modic change can so this patient went around from place to place thinking that it's TB spine because of this sort of end plate edema and sclerosis. But this is purely a modic change. This is a degenerative change. The other thing can be an osteoporotic injury or marrow edema because of that. And the MRI also vastly overestimates disease. So whenever you do a surgery, whatever you see in surgery is much less than what is seen on the MRI. And cost is also an issue. It depends on where you practice. But cost can be an issue, and availability can be an issue for MRI. I have a feeling that this is less of a problem now. And regarding cost also, there are people who do MRIs for 2,500 rupees also. So maybe it's worth doing it. The biopsy, we have seen already that there are 3 types, but the CT guided biopsy is by far the best, because the CT guided biopsy takes you in exactly and shows you the tip of the needle, the position of the tip of the needle. So in the various reasons for a failure of a biopsy, which would be, that the disease itself is less, or the lab is not good at culturing, or the technician or the sort of histologist is not good. One of the major reasons for not getting a positive biopsy is improper sampling, that you are not sampled the right place. And doing it CT guided gives you the best chance of getting a proper sample. And you can get such high yields, 88.5 to 96%, even in India. Now the thing is, to diagnose a TB spine, it is a positive culture. Like everything else is considered supportive evidence by WHO, but WHO for India and endemic areas has given some leeway that based on clinical and radiological features, we can diagnose TB. But having said that, for your scientific approach and for an international approach, the only way to say that this is TB is a positive culture, not even histology. And I think even gene expert is considered supportive. So you need to have a proper culture. And the biopsy material is likely to grow organisms when taken from granulation tissue rather than abscesses, because abscesses may contain more of debris rather than organism. So the granulation tissue will give you a good result. FNAC you cannot do, because an FNAC will not give you any report. You need to have a core biopsy, because the abscesses are usually very, very thick and the granulation is thick. So a fine needle aspiration will not give you anything. If there is no granulation tissue, you can do a bone biopsy as well. You can have false negatives as well because of this. So in culture, the TB MJIT culture is the gold standard, and it still takes 10 to 14 days before you get a result. We spoke about the gene expert test, which is a molecular test, which has a sensitivity of 95% and a specificity of 96% for spinal TB. So this is a huge value. And like I told you that it says the DNA is seen in 2 hours. Of course, we get the report in 48 hours because of maybe logistic factors, but you can practically get the report in 2 hours because it detects the DNA. And LPA is an even better test than that. Line probe assay is better than gene expert, where it can show you resistance to all of these: rifampicin, INH, quinolones, and second lines. So you can even know about MDR and XDR TB in just 48 hours. In biopsy, the key points are that a CT guided biopsy is better than fluoroscopy. So as far as possible, you make sure that your radiologist is trained and able to do these biopsies. And it may be that you also go to the CT department help, and that they do the needle pass in front of you. You need a core of tissue, not a FNAC, and you will get a better yield if there is soft tissue or granulation tissue. Try and send it immediately to the lab. Try to not store it overnight. And please don't put it in formalin, because formalin is only for histopath. The sample should be sent in normal saline, or it should be sent just plain in the container and sent immediately. That's the best thing. So result will depend not only on the disease, but also on the expertise of the various factors. So the expertise of taking the biopsy, of transferring the biopsy or transporting the biopsy sample, and the lab which is processing it. So Dr. Agashe, Aditya, we are very lucky that our Hinduja lab is like probably one of the best labs with a special interest in infections and TB. So we have been doing very well in terms of all of this. Now let's come to this patient. It's a 54-year-old male who's a diabetic, who's a CRF on dialysis, and has chronic back pain worsening over 3 months and leg pain as well. So this is the X-ray which we have seen, and this X-ray we have seen previously. This is the MRI as well, which is showing a paradiscal lesion. It is showing soft tissue. He's having leg pain because there is root compression. And the biopsy here was gene expert negative, and later on it showed a staph. So lesson number 1 from the other case was that all lesions are not infection, because that was a round cell tumor. Lesson number 2 from this is that all infections are not TB. So this is a staph. It's a completely different infection, and has to be treated separately. If you give AKT to this patient, you're unnecessarily giving a wrong medication for a very long time, and this patient may not get better. What happens is these patients sometimes get better because rifampicin works against staph, but the dose of rifampicin for staph is 600 BD. So you are underdosing them for staph and then going ahead with that. Now, what about empirical AKT? What is the concept of empirical AKT? So basically, empirical AKT means what? It means that you have a patient, you have been unable to come to a precise diagnosis, but at the same time, you are quite in favor that this is likely to be TB based on the clinical and the radiological features. So you may be wrong, but you are likely to be right, and you give AKT and you monitor the patient. So number 1, you need to give the proper regimen, whatever are the drugs. You can't give a half-hearted regimen. You have to give a proper regimen. You need to have a follow-up and have a decision-making template. And what is very important is to have consents, which means that you should explain to the patient that what we are doing is, because there is a chance that it turns out to be not TB, and this patient should not turn around and sue you that you gave the wrong treatment. So the patient has to be involved in this decision that, look here, we are not able to do a biopsy because of accessibility, or we have done a biopsy and the biopsy has failed. Now, rather than we can do a surgical biopsy if you want, or we can give you AKT and follow up your thing. But that consent is very, very important to be taken. So if you see this patient, again, with this sort of a lesion. Now this looks very much like infection. It's paradiscal. There is a collapse. There is an abscess. So there's clearly an abscess here. And this patient has another lesion at this lower point as well. And this is the CT scan showing collapse here and sort of a lesion over here. Now this patient, biopsy was done outside what was negative, and this patient was not willing. So this patient was actually ideal candidate for biopsy, but was not willing. This patient didn't have neurological deficit, so surgery we didn't want to do. So this patient was given AKT, and you can see after AKT what has happened. The abscess and etc. have dried up, right? So it has completely dried up. This one has filled up. This one has consolidated, and therefore this is a positive result of giving TB, and hence we give of giving AKT have made a retrospective diagnosis of TB. So this is sort of empirical AKT for this patient who has completely healed up. So the question is biopsy mandatory? It is mandatory because number one, you can have a mistaken diagnosis, which means either you have a non-TB infection, you can have resistant TB, or you can have other etiologies like METs, etc. It is important for scientific communication and for publication, and it is also important for medico-legal safety and requirement. So that is why I think today the teaching or the has to be that biopsy is mandatory, and in practice as well, the aim is that you should go for a biopsy as much as is feasible. If for some reason a biopsy is not done, either because facilities are not there, it is too difficult, patient is not willing, you need to document that a biopsy is being advised and it is being not done as a choice, because any medical legal issue is always negligence. It is not a decision which is not right. So your decision to not do a biopsy may be right, may be wrong, but it is not negligent if that decision is made with forethought. So you need to document all of that. So how do you catch them early? Clinical suspicion, investigation, and a biopsy. So the key issues were when to get an MRI, and I've already told you about the red flags. When to get a biopsy almost in every case. What to do when the biopsy is negative. The key points are CT is better than fluoroscopy. A core of tissue to be done, not FNAC. Soft tissue is better. Send immediately. And so I think this slide has come a second time. So if there is a negative biopsy, what do we do? So this is also important. If the biopsy is negative, you revisit the clinical and imaging features, assess the patient right from scratch. If there is a secondary surgical indication, which means this patient has got partial deficit or this patient has been pain, collapse, and this patient would be borderline for surgery anyway, then this may push you in the direction of surgery, that the additional indication for surgery is to get tissue for the diagnosis. So this would not be a prime indication for surgery, getting the diagnosis, but it's an additional indication which may weigh that patient towards surgery rather than conservative. And if you don't operate, then you review, you discuss, and then either you can do the second biopsy, or you can do an open biopsy, or you can give an empirical AKT as discussed, but it is to be done with discussion, consent, and documentation. So this is as far as
Thank you very much, Dr. Dalvi.
Yeah.
Thanks a lot. Now, a couple of points he has stressed, and I would like to stress again.
If you can just talk for 2 minutes and get a little rest. Yeah.
Yes. Couple of points he has stressed, and I would like to re-stress, and that is the gold test as well as Mantu. Gold test, in fact, has been banned, and please, I mean, it's really surprising that people still keep doing gold tests. So it is best to avoid that. And of course, last time also we had stressed that gold standard is culture. You need to have a complete diagnosis of tuberculosis. You may start anti-TB drugs. You may, if you are not able to prove the diagnosis after doing tests, or if the patient refuses surgery, or is not biopsy, or is not fit for biopsy. But that also under supervision as well as consent. So these things are very, very important. And as I said last time, that in most of the even district places, TB cultures are available. May not be MGIT, but at least LZ. Yes, Dr. Davi.
So I think, are there any questions from the audience?
Yes.
Sir, one question.
Yeah.
So many times the culture report have come negative after biopsy, but we have seen granulomatous tissue on the histopath.
Yes. So basically, like I said, there are three important tests which we are doing. One is the histology, one is the culture, and the third is the gene expert. Now we hope that something of this comes positive. If the gene expert comes positive, it is still good enough reason to start AKT. If you see caseating granulomas, then again you can start AKT. I think the only thing is that there are NTM, which is non-tuberculous mycobacterial infection, which are also there, but they are very uncommon infections. There is an infection called myeloidosis also, which is seen in sort of veterinary or in children who are in farms. There are some, but if you see granulomas and caseating granulomas, you have a very, very high chance that this is TB and you can treat with AKT. You of course need to follow up these patients as well.
So, sir, we need any other investigation like PET scan or something to.
No, a PET scan is absolutely non-specific. A PET scan is sensitive, but it has zero specificity.
Okay. Thank you.
So a PET scan, and it is still very much an investigational tool, PET scan. But even for the, I did a talk on ending of AKT, and even for that, it is just a very much of an investigational tool at this point in time. It has not really been established in any way. In addition to the fact that it has a lot of cost involved, it's 18 to 20,000 rupees. So I don't think one can really say that PET scan is an investigation.
There are a couple of questions on TB, PCR, and CB.
Yes, could you answer those? Aditya, do you know the answer to those?
Yeah, so TB PCR is something we don't do. It's gene expert is the nucleic acid amplification test that we do. We don't really recommend TB PCR.
But I think LPA is the one which is now being done, which is a very strong test.
Yes. Yes, and that's there in limited laboratories. It's now increasing in numbers in other district places, but currently it is limited to the recognized laboratories, few of the recognized laboratories. And the other thing that is being rolled out now is the Gene Expert MDR, XDR.
Right.
So that will also give us an idea about fluoroquinolones and aminoglycosides immediately.
I think still the most important thing is to build up the expertise in your CT department to be able to do these biopsies properly. Like we are blessed that we have good interventional radiologists, but to talk to them, to encourage them to do even difficult cases and to see that the needle position is right and get the tissue right and send it straight to the lab. This is the one which will give you the answer to most of these cases.
Correct. And CBNAT is basically another name for gene expert. That's the molecular name for
gene exactly. CBNAT is gene expert. That's what I was thinking.
Yeah.
Yes. Okay. So I'll go back to the next talk. So we'll start this and then we'll take a break in the middle. It's got 140 slides. So I think the aim, if you were to understand, the first part is the very, very important part because it is analysis and diagnosis of a case of TB spine, which is, winning half the battle. The second half of the battle is obviously managing it. And I think this sentence is very, very important that compared to what we thought 10 to 15 years ago, spinal TB is actually a medical disease and surgery is reserved for its complications and sequelae. So the clinical presentations are these. We have seen this, that they present as an inflammatory back pain, which is not relieved completely by rest. There is night pain and there is marked tenderness and spasm. They may or may not have constitutional symptoms and other histories. They may present with neurology. they may present with deformity, but finally they can have any presentation. And what I've seen now, that there is no age, sex, social or economic group which is spared. So I've had 2-year-old children with TB spine, and I've had 90-year-olds with TB spine, males, females, of course. I've had millionaires and industrialists with TB spine, and farmers, taxi drivers, and beggars with TB spine. So there is really nothing which is spared in all of this. The plain X-rays show paradiscal lesions, soft tissue abscesses, but there can be unusual presentation as well. Though we are taught it is paradiscal, you can have a central body lesion as well. They may present as only epidural abscess. So these patients, this is known as spinal tumor syndrome. So what is spinal tumor syndrome? Spinal tumor syndrome is that patients present like a tumor. Clinical presentation is like a tumor, means they don't have any back pain or anything. They just present with neurological deficit. And it's only when you do an investigation like an MRI do you see that there is an epidural abscess. So this is known as spinal tumor syndrome. We've already spoken about the investigations, so I'm going to go through this. And what we look in the MRI are these things which are pointed out earlier. We look at the destruction, we look at the abscesses, you look at the intracanal abscesses, you look at the prevertebral abscesses in the axials, the vertebral destruction, and identify the spinal cord. So this is what a montage of a TB spine would look like. But this is what it looks like when it is treated. So when you treat, you can see that the abscesses start shrinking, the bone starts reconstituting, the marrow starts reconstituting. That's another one where you can see a paradiscal lesion with collapse and cord compression. And in 3 months, you can see already that you see that all the edema has gone down, the soft tissue has gone in, there is no cord compression anymore. And in 9 months, it is like completely healed up. Now, what we do, the treatment, what we follow in India, thanks to Professor Tully, is the middle path regimen. Now, why is it called mid path regimen? I will explain to you why it is called in case you didn't know that. Because in India, they used to follow the conservative regimen. Conservative regimen means give AKT, whether the patient is paraplegic, has pain or nothing. You just give 9 months AKT and nursing care, etc., sanatorium care, purely conservative. On the other hand, in Hong Kong, they used to use a treatment known as radical debridement. There they believed that every patient has to be operated. They felt that every patient who has TB spine has to be opened, debrided and bone grafted. So that is the radical debridement method, which was popularized by Hodgson and Stock from Hong Kong. So what Professor Tully said that we will follow a mid-path regimen. And this mid-path regimen is what we follow. So mid-path regimen means that every patient gets AKT. So we've already in the past lectures probably discussed the AKT, but I'll tell you what I follow because there are various different regimens. I follow the WHO regimen, which is slightly modified by India, which is 4 drugs for 2 months and 3 drugs for 7 months. So I give 9 months of AKT. Rest is important, bracing is important. So why are these important? Although the sort of the big trials, the MRC studies have said that they don't make a difference, but practically, if you give rest, the patient heals faster. If you give bracing, the lesions heal faster and the patients have less pain. What is important in the middle path regimen is to review the patient. There is no patient who will come to you as a TB spine, who you write the drugs and tell them come after 9 months. You have to review them periodically. You have to make sure that your drugs are acting, that the patient is getting better. You have to make sure that there are no drug side effects or something else is going wrong. You need to look at various things. You look clinically, you look at the general well-being of the patient, whether the patient is really getting better or not. You look at the weight gain. So chest physicians are very fixed on this concept of weight gain, but I think it shows that it is working. You look at the local pain, the patient will tell you that the pain is getting better. You look at the tenderness and whether they are getting deformity or not. You need to follow up serial X-rays to make sure they are not getting deformity. And you need to have a careful evaluation of neurology. You also do follow-ups like the ESR. Like I told you, ESR is a decent guide. It's not the world's best, but it is cheap and easily available. So if you have a patient who has an ESR of 70, coming to 50, coming to 30 and 20, that shows that the drugs are working. You also look at X-rays to look at the various things. You will see reconstitution. You will see soft tissue abscesses maybe getting less. And you may sort of see that they are not going into a deformity. And you can do MRIs as well. And what I do for most patients, but not necessarily all, is to do an MRI at 3 or 4 months in the first phase of treatment. and then we do one right at the end of the treatment at the conclusion to document that it is done. So an MRI, just as it is sensitive to pick up the TB spine, it is also sensitive to look for the response for TB spine. So the medical management alone is highly effective in treating spinal TB, irrespective of what the MRI looks like. So initially also I showed you the first patient which we saw had these huge abscesses, and anyone would say that it needs to be drained and 4-level involvement and huge cord compression. And your first thing you'll think of is surgery. But the thing is that the AKT works so well in the cases that everything dries up and everything gets better. So this is one case. We have seen this case earlier, unfortunately, because these are very different presentations which I've added. But again, if you can see, this is what it looks like, 2-level lesion. And in the CT, there's actually destruction. So somebody may say that, okay, there's a collapse and cord compression, and here there is sort of a cavity. So this patient needs to have surgery. So this may be the thought. But you can see even in 3 months AKT, the entire cord compression has gone and this cavity has started filling up. And in 9 months, after 12 months AKT, this patient has completely healed. So you see this body has completely reconstituted without surgery. This has completely, it has collapsed, yes, but it is completely healed and there is no cord compression. So this is a very, very good result, which you can see. So surgery is the exception rather than the rule for TB spine. And this is very important. What are the indications? So when you say you're following the middle path, it means that you follow the conservative path. And at some stage, you may have to deviate to the surgical part. So what is important to know is when do you need to intervene or when do you deviate your path? And I would group these as 4 big groups of indications. The first group is neurologic. The second group is disease factors. The third is deformity factors. And the last is debilitation. So these are the 4 groups. In fact, this was previously also mentioned by Butler, which was way back, in the 19th century. I am just paraphrasing these into these 4 groups. So let's look at each of them separately. What is the neurologic indication? Number 1 is dense deficit on presentation. So if a patient comes to you with grade 0, 1, 2 power, patient not able to stand, not able to walk, this patient should be given the chance of surgery, because although with medical management he may eventually recover, but with surgery he's got the best opportunity for recovery. With a safe surgery, he has the best opportunity for recovery. The other issue is deficit appearing on treatment. So you have a patient is nil neuro, but 6 weeks down the line starts getting down off his legs. So something is going on wrong there. Maybe there's a sequestrum pressing on the cord, or there is increased, there are some sort of resistance, but this patient needs surgery. And if the patient has a deficit which is just not getting better, they need to be operated. The second group of indications is disease indications. One of them is no response. So if you're giving AKT, but the patient is not getting better, that would be one indication for surgery. If there is continued pain, like the patient may be getting better in terms of an MRI, but the patient is continuing to get pain and just not getting better, like 2 months, 3 months. And if you have a diagnosis in doubt, what I told you earlier, that the diagnosis in doubt becomes a secondary indication for surgery. It's not a primary indication, but it's a secondary indication that you have the other indications which are soft. You add another soft indication and that may take you towards surgery. The next is deformity. Childhood TB is a separate chapter and I'm not covering it today because it is too vast a chapter. Extensive or circumferential destruction, where you know that this patient is going to go into a kyphosis, or if there is severe deformity at the onset or progressive deformity. These are the patients which we need to operate on and make sure that they don't have deformed spine. And lastly, debilitation. So what do you mean by this? That there are some patients who are elderly patients who are really bedridden for a very long time. They are not able to get up because of pain. These patients may benefit from debridement and stabilization for an earlier cure of the disease. Now coming back to the first indication, which is the neurological indication, we need to know when we are operating these patients as to what is the cause of the neurological deficit, right? So the cause, we all know or we all feel is compressive is the main cause, and compressive is the main cause. There is no doubt about it. But there are also non-compressive causes. So there are vascular changes which can take place, and there can be meningeal changes like a meningitis or arachnoiditis, etc., which can be a cause of a neurological deficit. What is the compression? The compression is classified, can be sort of thought of in 2 kinds of compressions. There is soft compression or hard compression, just in a sort of a ballpark sort of thing. So what are the soft compression? Soft compression are abscesses under pressure. So these abscesses under pressure, they compress the cord. Inflammatory exudates, granulation tissue, like there may be a carpet of granulation tissue rather than an abscess. It can be just a carpet of granulation tissue. What about the hard structures? There can be sequestrae of disc and bone. So the disc and bone pieces may sequester and sort of hit the cord. Internal gibbous. So if there is a deformity, the internal gibbous may form a ridge which can compress the cord. And a translation can also, like a translated spine can cause. So I will just show an example. This is an abscess under pressure. So you can see this is the abscess wall and this is pure abscess. There is nothing else here. This is granulation tissue. So this is not an abscess. This is a, you can see the consistency of this. This is a carpet of granulation tissue. See this, all of this is granulation tissue. This is not a tense abscess. This is a sequestrum. Beautiful picture. You can see there's a sequestrum of bone and disc. And I actually found this during surgery. This is a patient who got deficit while on treatment. And this is an internal gibbous again. So what is compressing? So there's no amount of AKT will help this patient because what is compressing the cord is this angle, the internal gibbous. And this is a translation. You can see this one column is here and one column is here. So the cord is getting translated. So the cause of the neurological deficit here is a translation of the column. Here again, there's a translation of the column. In addition to the soft tissue, the column is translated in front. So if you have things like abscesses and granulation tissue like this, that's another beautiful picture of granulation tissue. You can definitely give a conservative trial because these will resolve. Sometimes you add a little steroid, but they can resolve and the cord compression can get resolved. But if you have a hard compression like a sequestrum, like a bony gibbous such as this, or a translation, then there's no point in giving a conservative trial because AKT is not going to help this situation. It's a hard compression and these patients then need to be operated. So if you look at the clinical algorithm for a patient with neurological deficit leading to surgery, if the patient has a dense neurological deficit when he comes and he cannot stand, this patient has to go in for surgery. If the patient has a milder deficit, then this patient in the mid-path regimen goes for conservative with all of these. And if there is no recovery, then the patient goes for surgery. If there is static or slow recovery, this patient may go for surgery. Or if the patient gets a deficit during treatment, this patient may go for surgery. But otherwise, these patients are treated conservatively in most of the cases. Coming to the next sort of indication for surgery, which is disease related. What if the clinical response is poor? There is continued pain, the MRI is not improving, and markers, weight, ESR, etc. are not improving. So pain, you are following up with the MRI, it is not getting better, weight is not getting better, ESR is not coming down. What are the causes of this poor response? One of them is resistant disease. So if you have resistant disease, obviously your AKT isn't working. And if your AKT isn't working, then obviously the patient is not going to get better. But you can have mechanical factors. So the mechanical factors can be like an instability which is developing or a kyphosis which is developing. And that can be a reason. So your disease is getting better, but a mechanical factor is causing pain. A mistaken diagnosis, we've already been through that if you give AKT but it is not cox spine, then that's a problem. So what do you do in a patient with poor response? You review the case. You go right to the basics. You look at the diagnosis. Was your diagnosis correct? Look at the biopsy, the results, maybe discuss, are they 100% sure? On what basis have you started the AKT? And you study the structural aspect. You need to get x-rays, you may get dynamic x-rays to see the structural aspect of the thing. If there is an instability, you have to treat on merit. So if there's an instability, maybe you can still give bracing and AKT and the patient may get better because it may be a temporary instability. But it may be that you need surgery to stabilize the patient to get him better. But if it's a disease factor, like a late responder or a resistant patient, then you may have to change the AKT. You may need a debridement. So you may do a repeat biopsy, etc. Or you may just do a debridement in which you get the tissue and you can find out what's happening. Now, what is the role of MRI in these patients who are late responders or in all patients? I think there are some important facts which you need to know. That is, the resolution of changes takes 3 to 4 months. So, if you do early scan, in fact, if you do a scan at 1 month, it may actually show worsening. There may be worsening of the disease. And a lot of people do that and they're worried and they may go in for surgery. But that is a normal thing in CNS TB, that initially the MRI looks worse because, although the patient is getting better, the MRI looks worse. So don't do early MRIs. I think I do MRI at 3 to 4 months. Very rarely, if the patient is deteriorating, would I do an MRI at 2 months. Now coming to surgery, what are the principles of surgery? Basically, what we do is we do a debridement. So by debridement, basically any orthopedic debridement, we try and remove granulation tissue, abscess, necrotic bone, etc. We try to remove all of that till we get good quality bleeding bone. We do a decompression, which is another important part of the operation, where we make sure that the spinal structures are not decompressed anymore and are not compressed anymore. And at the end of it, we do a reconstruction. So in addition to the fact that the disease has damaged the column, also the surgery also damages the column. So when we do the debridement decompression, we are removing bone, and there is a resultant instability, and we need to reconstruct that. And the decompression and the reconstruction, they go hand in hand. They are not separate issues. Like you cannot just do a decompression and come out. You have to do it together. Here we now come to the zone concept in TB spine when we are planning these. So there is an anterior zone, because as we know, TB is an anterior disease, and the anterior zone is a zone of disease. And this is used for decompression and debridement and reconstruction, because that is where the disease lies. And then there is the posterior zone. So the posterior zone has intact elements. So in a normal TB spine, the posterior zone is intact, and this can be safely used for instrumentation and fusion, because the disease is anterior, the disease is not posterior. So what are the strategies for decompression? Basically, you need to make an adequate approach. You need to have an effective decompression. You need to have a reconstruction of the defect. So I'm just going to take a small break just now, because it's now past 8. And the reason I'm taking the break is because we've done one chunk of this. And if Dr. Agashe and if there are doubts about a decision making, we are going into surgical specifics right now. But if you have any doubts about the decision making, you can just ask me, or we'll take maybe a 2-minute break. I'll just get my heat my tea. And if there is any doubt so far, then let me know the doubts on the decision making. Because the first part was extremely important, because that was in the assessment and diagnosis. Now the second part has been second part has been on the decision making, as to how do we overall holistically plan the management of these patients before getting into the specifics of the treatment. So this is the second very, very important part, because you may or may not do the surgery yourself, because now there is an era of specialization, and everybody doesn't want to do everything. It depends on where you're practicing. If you're practicing in a smaller town, you may be forced, or you may have to do the surgery yourself. Or if you are practicing in a multi-center sort of, you may want to refer this patient. But you need to know the principles of managing, of decision making. And I think this first part of the talk was for that. So if there are any questions on that, you can please ask. While I heat my tea, Dr. Agashe and this one will also answer.
Yes. Enjoy your tea. Now, at this juncture, I would like to say that TB spine is a medical disease. While as regards peripheral joints are concerned, or osteoarticular extraspinal lesions are concerned, we tend to do surgery, especially when it is intra-articular. So if you remember, we had said that stage 1 is only synovial involvement. That is the time when we would definitely conserve the patient. Extra-articular lesions, we would definitely try conservative treatment. But once articular surface starts getting involved, it is best to operate. As opposed to TB spine, where stiffness doesn't matter of that lesion. Fusion doesn't matter as regard that segment is concerned. So you need to understand that TB spine is a medical disease unless proved otherwise, while peripherally, we need to classify them and take a call. Dr. Menon, would you like to add something?
No, so I think that's summarizing it perfectly. So the idea is getting the tissue biopsy. So in peripheral joints, when it's intra-articular, the biopsy itself becomes diagnostic and curative, therapeutic. So it serves both purposes. So instead of doing a needle biopsy, waiting, and then probably not having negative cultures, by then the joint is already destroyed.
Right.
3 weeks can be a significant amount.
So
Whereas in
needle
spine, unless there
biopsy,
is, yes.
sorry, go ahead.
No, go ahead, sir.
So needle biopsy would be important in stage 1, where it is synovial, or extra-articular stage 2. It also may be useful in stage 4 when there is a tremendous destruction. It may be useful. But as regards stage 3 is concerned, surgery would be more important.
So, I mean, comparing it to spine, the neurodeficit in a dense neurodeficit in spine would be comparable to intra-articular damage in joints.
Somewhat.
So
yes.
those two would go hand in hand and we would operate.
Correct. Correct.
Whereas a posterior or just a paradiscal lesion would be like a synovial lesion in joints, and then you do a image-guided biopsy versus maybe a surgical biopsy if image-guided either is not available or is negative. And if you're still in doubt of we still want the tissue type.
Any questions you have apart from whatever are put up on the board, which Dr. Jalvi will answer?
Sir, I have a question.
Yeah.
Sir, demonstrated that case with cervical tuberculosis. That patient presented with a soft tissue collection without any neurodeficit. Sir, in that case, I'm not talking about the definitive surgery like decompression or instrumentation, but need we go for at least abscess drainage in such cases, or is it just we have to follow up after starting the patient on AKT? We just have to follow him up for development of neurodeficit or respiratory or any such compromise.
Yeah. So
Dr. Darvi, I would like to continue that question.
Yeah, I'm back. You want to ask? Continue the question. Yeah. Ask
Me. When you are doing a biopsy, and in presence of an abscess, rather than doing just a small biopsy, why can't you just drain the abscess?
No, so it would depend on what the situation is. So, see, I think there are some concepts which one has to understand. One of the concepts is that the size of the disease has no correlation with the cure. So even a large abscess is as well treated as a small abscess. So it is just intuitively that we feel we have to drain an abscess. So for TB, I'm not talking of pyogenic. So there is no role, like, because I have got other patients also with huge source abscesses, etc., which we are not able to drain easily, or other abscesses which we don't reach. So they also get well. So why should an external abscess be drained? The indication for draining an abscess would be pressure effects. So suppose this patient had serious dysphagia, etc., then we would have drained the abscess. But other than that, there would be a diagnostic tap, but not necessarily a therapeutic tap. See, why do we not drain? There are 2 or 3 reasons for it. Number one, suppose we had done an incision and drained it. There is also a chance that he will land up with a sinus when he didn't have a sinus at all. He has just come with an abscess and pain. And if he then lands up with a sinus, that sinus will take 3 months to heal. He will be miserable. So that is one of the reasons. The other thing is there's a very interesting phenomenon in the cervical spine and especially in the C1, C2 area. So what happens is when there is destruction, a bony destruction, there is a tense abscess which keeps the alignment in place, right? Now, if you disturb that, this patient can go into a sudden instability and severe pain, right? And there are cases of, Dr. Ingaladikar had a case and other people who had a case of a C1, C2 patient with a prevertebral abscess. And it is very tempting to do a transoral drainage because you feel you have done a transoral surgery and you feel great, and it's a very simple. All you have to do is put a retractor and nick. But that patient died on the table because immediately that C1, C2 dislocated. So it is the abscess which is keeping the alignment in place. And over a period of time, what happens? There is a reconstitution, reduction of the abscess, fibrosis. So the spine alignment is maintained. So it is not necessary that why do we not drain the abscess? But it's not like that. There are 2 issues with that. The first thing is that it's not needed. That's one side. But there are also downsides of it. One is sinus. That's the worst thing because I have seen patients who just come with a sinus. They said ki kuch nahi tha. They could easily be treated with AKT, but somebody decided to make a nick, and then the patient has a sinus, and these sinuses take 3 to 4 months to dry up. Okay.
Instability is a very, very important thing.
Yes. So I think that this was your question, but before that, Ayesha had asked the question, which was it the same question, whether we should drain it or not? It was the
Yes.
same question.
Same,
Yes, sir.
same.
Same
I just extended that.
Okay, okay. You said why not, and she said
Yes.
why. So I said, yeah. If it is pressure effects, then yes. If it doesn't have pressure effects, then no. So we've had patients with huge psoas abscesses who we have not drained, and then we just follow them up and they get better. You know.
Does that answer your question, Aisha?
Yes, sir. Just one thing, sir. So is it wise to just send them back home? And is that like, I don't know, I have never seen a case of such cervical dorsal not being operated. But sir, is it a likelihood that they will go back and land up in sudden respiratory arrest or something from dyspnea or
No,
dysphagia?
no,
Is
no.
it?
TB is a slow disease.
Okay, sir. Okay, sir.
There's one couple of
TB is a
questions
slow-
on middle path.
Yeah, yeah. So there's a
What
question which
does
is on the
rest
slide,
mean?
right? On the slide, right?
Yes, yes, yes.
Yeah. So what do you mean by rest in the middle path? So see, it is a very vague term actually, because essentially you have to be practical. If you look at the British MRC studies where they did these these trials, they did these trials and they compared ambulatory chemotherapy versus rest. They compared bracing versus no bracing. But these are scientific studies where the large population is studied and they look at overall. But you are treating an individual patient. Now, you cannot tell a patient who has got severe pain that British study has showed that rest is of no use. So you bear the pain and move around. You have to be practical. The patient has pain, you need to have a rest for the patient. But there is no fixed time. It is not 3 weeks or 6 weeks or 3 months of rest. You let the patient rest till the acute pain is over. And then you make the patient mobilize and you give them a brace for another till the bone starts reconstituting and then take it off. So there is no fixed timetable. It's a call based on how each patient is behaving. So it may be longer for some patient, it may be less. So if a patient comes to you with very little pain, he's already moving around, going to office, etc., and he just comes with an MRI finding of TB spine, that patient you don't necessarily have to put on rest if he's comfortable. So that was one question. ESR to be repeated every month yes, it can be, because it really doesn't cost much and it's a good guide. Which brace and dependent on side of the lesion. So yes, so the brace of course depends on where it is. If it's a mid cervical, then it's a collar. Initially it may be a Philadelphia collar, later a soft collar. If it's a dorsal, then we use up to sort of the dorsal spine, the upper sort of mid dorsal, we would use a Taylor's brace. If it's up to the dorsolumbar junction, then that Taylor's brace should have axillary clutches as well. And if it's a pure lumbar, then you can use a high LS frame type of belt. Rest we've already told. When to mobilize we've already told. When diagnosis is in doubt, should we take consent for surgery? So this I've said 3 or 4 times, that to establish the diagnosis becomes a secondary indication for surgery. It's not a primary indication. But if, for instance, if the patient has pain, patient has been in bed for 2 months, patient is showing collapse, and also the diagnosis is not known, then you can tell the patient that these are the 3-4 indications why I'm doing the surgery, and then you can go ahead with the surgery. But it is not the sole indication for surgery.
So how does the axillary support benefit in a dorsolumbar?
See, basically the axillary support is to prevent rotation. It is not meant to bear weight, because the axillary support is not supposed to dig in the axilla. It is to prevent rotation. So rotation takes place at the dorsolumbar junction, D11, D12. So it will prevent that rotation. Whereas for the upper dorsal spine, a plain Taylor's brace is okay, like T5-6 for that. And if it's even higher than that, it becomes very difficult, because if it is D2, D3 or D1 cervico-dorsal junction, you have to have a 4-poster brace or a SOMI brace. No, the sterno-occipitomandibular sort of immobilizer, or a 4-poster collar. So those are a little more difficult to treat. One second, there is which 4 drugs do you select for the first one? So we start EHRZ. So rifampicin, INH, pyrazinamide and ethambutol. Not streptomycin. I think streptomycin, there is no point. It's a bacteriostatic drug. It's very painful and it has got a lot of side effects. So definitely not. So these are the 4 drugs. And after that, we stop pyrazinamide. After the first 4, it's not for the first 4 months, it's for the first 2 months. And after 2 months, we stop pyrazinamide. Pyrazinamide is stopped because of a few reasons. One is it is bacteriostatic. And secondly, pyrazinamide has tachyphylaxis. It doesn't act after 2 months. And it takes care only in that intensive phase. So there is no role later on. Ethambutol, there is a reason why ethambutol is not in the WHO regimen, but ethambutol is in the Indian regimen, and that is because of a high incidence of INH resistant, which is, this INH resistance may not be detected, but in India there is a high incidence of primary INH resistance, and that is why ethambutol is also given in India. So there is one Indian publication or an Indian recommendation whose name at this moment I'm forgetting, but they have recommended to give ethambutol. So this is what I have been doing, 3. So WHO in fact is 4+2. They give only INH rifampicin, but in India we give ethambutol as well. In fact, now there's a lot of controversy there. They are saying that even 6 months is enough. There are some papers also. The paper quality is medium. It is not great quality paper, not bad papers. But even 6 months AKT has been tried. But I think I'm just comfortable with 9 months of AKT. I did understand your question, Tarun, that during surgery to confirm diagnosis, do we need to do therapeutic? Yes, of course. Yes, I understood that question now. I said, if you're doing a surgery, then you should do everything. Unless you're doing only a biopsy, that's a different story. But otherwise, yes, you have to do the full surgery because there's no point. You have to do a decompression, debridement, and reconstruction. Regarding the drug answer, I may not be the best person because I refer all my patients to infectious disease consultants. But I do know that we have to give them pyridoxine, Benadone or pyridoxine to prevent peripheral neuropathy, 20 milligram a day. And you need to, when you're giving ethambutol, you need to get the eyes checked from time to time. And you need to follow their SGOTs, SGPTs. So that's the very least as orthopedic surgeons which we can do to monitor these patients. So liver function, create as well, though not so important. Eyes for ethambutol and peripheral neuropathy you need to look at. The other thing is that one thing which I think you should really know is that if patients get joint pains, you need to do a uric acid because pyridoxine causes, pyrazinamide causes hyperuricemia in some patients. So these are, 4 or 5 things which even an orthopedic surgeon should know about AKT. Okay. So should I progress? Should I proceed with my
I think so. Please.
Yeah. Because it's quite intense from now on. There's a lot of, because I think even if you go away with what you have learned so far, it's good enough. Now the rest of the thing will be maybe a little more like a sort of a, we are going to, going to watch a little movie with a lot of fancy stuff in it. But I think we need to do it to complete the topic because you need to know what is to be done and what can be done and what it is that we do. This talk, how did it go to the beginning actually? I had come up to a point in this, right? One second, sorry. Yes, I think this is the point, right? Is everybody seeing the screen? Aditya?
Yes. Yeah. Please go ahead. We can see.
So now we are coming to the specifics of surgery. The strategies for decompression is you need to have an adequate approach. You need to have a proper approach. You need to do an effective decompression and you need to be able to do a reconstruction of the defect. Now, as we have discussed previously, vertebral tuberculosis is an anterior disease and therefore any surgical attack must access the anterior column. I'm not saying it has to be an anterior surgery, but you have to have access to the anterior column. And in the cervical, it's an anterior cervical approach like an ACDF. For the thoracic, it used to be a transthoracic approach. For a lumbar, it's a retroperitoneal approach. And for the junctional areas, it becomes difficult. So I've got slides on those as well. For T2, T3, it's a transternal approach. And for L1, L2, it's a transdiaphragmatic approach. For the L5, S1, it's a transperitoneal approach. So the junctions are very difficult to access. For instance, the cervicothoracic junction, which lies at T1, T2, T3, behind the sternum as well as the great vessels. This becomes very difficult to access. And what we do is previously one of the things which were described was this, where they do an excision of the medial end of clavicle and the manubrium and use it as a bone graft. But this was done in the previous sort of cowboy surgery days because this leaves a very bad cosmetic deformity. And what we do now, if needed, is a partial sternal split. So I will do an osteotomy of the manubrium like this, a T-shaped osteotomy, and put in a spreader and open it. So this sort of thing, and this is this is across the cervicothoracic junction. This is the esophagus pushed on one side, and this is the prevertebral fascia, and this is a plate which is put there. The other junction, which is the thoracolumbar junction, is a problem. So what you have to do is that if it is above T12, you can do a transthoracic or a thoracotomy through the 10th rib. But if it is L3 and below, you do a retroperitoneal approach, which again is a standard approach. You cut the muscles 3 layers and put the pleura, the peritoneum in front and reach the spine. But if it is L1, L2 or in continuity, you have to do this fancy sounding procedure, right? Which is just to impress you all. But essentially the procedure is a transthoracic retroperitoneal, which is then connected by cutting the diaphragm, or a transdiaphragmatic approach. So this is the approach where we first do a transthoracic, we remove the rib, and this is the diaphragm. So we peripherally cut the diaphragm all the way around to connect the lumbar and the thoracic spine, right? So that's the chest retractor, that's the diaphragm, that's the peritoneum to go into the lumbar spine, and that's the approach for reaching anteriorly. So I'll come later on to the modifications of that. In decompression, what do? We drain the abscess, we remove the sequestrae, and peel off the granulation tissue till you visualize the dura. Now, there's one thing I must tell you: in TB, you don't have to remove every last bit of tissue, because AKT also will work. You just need to have a gross clearance and a gross decompression. So don't just go on digging around the cord. And if there is an internal gibbus, you need to remove that. So this is an MRI, a standard classic MRI, where there is a collapse and there is cord compression here because of granulation tissue. And after surgery, transthoracic surgery, I did an MRI. And this is sort of the anterior decompression. This is an empty space. There's nothing over here. And this is the graft. This is the bone graft which is put over here. So this is a pure anterior standard transthoracic operation. And if you do a CT, it looks like this, where there is nothing in front of the cord over here. It's all removed. And there is a graft which is placed over here. So this is another one where this was the disease. This is the disease area, which has all been excised. And you put a graft from this bone to this bone. So this is the graft. So these were all done way back before we started using instrumentation. And it still all worked because the bone graft used to fuse up. So this is how the bone graft fuses up. As you can see, there's a graft placed from there to there. What about reconstruction? So the bone grafting is very important. You need a strut bone graft, or nowadays a cage, from a good bone to a good bone. Because if you put it from bad bone to bad bone, it's going to loosen out. So this is the kind of strut graft which you put in the defect. We now use instrumentation as well, because with increases the stability, increases the safety, you can mobilize the patient and you can correct the deformity. So this is what it looks like from an anterior approach, that after decompression, there is a end plates which are seen, in which you can put the bone graft as a strut bone graft. And then you can put in an implant if you want to. So if you look at this patient, L34 Cox, given AKT, but not getting better, further destruction, this patient was taken for a posterior fixation and then turned around, and an anterior debridement and bone graft was done for him. That's another one where early lesion, this patient we have seen earlier, but came to us late. And in spite of AKT, this patient then went down. And this patient now has multiple indications for surgery, because this patient has got destruction, patient has pain, patient has kyphosis, and patient has neurological deficit. So this patient is indicated for surgery. And what we do is we do this. The back and front was done. So a posterior fixation and an anterior fixation, and the anterior strut bone graft which was put over here. That's another one where multiple indications for surgery: cord compression, extensive disease, deficit, as well as translation. So this patient had translation. So just AKT would not be enough for this patient. And this patient is done a fixation as well, and then anteriorly turned, and after fixation, turn the patient anteriorly and then do a debridement and bone graft. So this is the bone graft. This is another patient, just to show you the anterior approach. Standard TB spine, after 6 months AKT, actually the disease has healed, but the way this vertebra has collapsed has caused cord compression by an internal gibbus. And you can see the cord is compressed, and you can see the signal change in the cord. So this patient was densely myelopathic. And here again, AKT is not going to help this patient. We have to remove this. So this patient was operated anteriorly, and sort of a anterior implant and cage was put. But now you don't have to be scared about the anterior approach, because anterior approach is something which you require experience with, and my generation still has it, because I was doing a lot of anterior surgery. I do not call a chest surgeon or anything with me. I do my transthoracic myself, retroperitoneal, everything I do myself. Even the trans diaphragmatic I do myself because we do it for scoliosis as well. But now there is a penchant, especially in TB, to use the transpedicular approach. What is the transpedicular approach? We still reach the anterior column, but we do it from the posterior approach. So the principle of surgery still remains the same. You debride, you decompress, and you reconstruct, but you have to fix posteriorly. It's a bit of a tangential approach. So what happens is, this is the disease. It is still anterior we have to reach, and this would be how you would reach it from an anterior approach. But this is how you would reach it from a transpedicular approach. You would go tangentially around the cord to the side, and because the pedicle is excised, you get access to the anterior column. So this is a case which you can see there is a collapse, cord compression, etc. It's at D4, which is a tricky level, and this patient was treated with a TPD. So we put screws and we remove the pedicle from one side, go anteriorly, and then this cage is put from the back. Also now we do MIS surgery for this, and this is one patient where a debridement and fusion is done through a mini approach. So an infection, and just by this is done through a MIS approach, just small incisions. This is another one which is a dorsal one with cord compression, where this patient insisted on MIS, but as you can see, we have put these screws through separate small incisions, and here is a small opening through which I have done the decompression under the microscope. And see, that's all. So from here, just to put the curate to show you where the defect is for the transpedicular. That's again a C-arm to show you where the curate is. And we put in the screws and the rods, everything through sort of small incision. So rather than a big middle incision, so the number of incisions are more, I agree, but there is no muscle destruction. So each place the rod is threaded through this. So even though the surgery is so long, such a big length of surgery, there is no midline dissection which is done. What about deformity? So like I said, the first indication was neurological. The second indication was disease. The third indication is deformity. So if there is a progressive deformity, so you are following up these patients, and if there's a progressive deformity, then there will be an issue. If there is a dorsolumbar junction deformity, there is an issue, because dorsolumbar junction deformities are poorly tolerated. If you have a dorsolumbar kyphosis, these patients have lumbar lordosis for the rest of their life, which is very painful. If there's circumferential destruction or loss of multiple vertebrae, and childhood TB. So these are the indications. These patients are at risk for getting deformity, and they need to be operated as an indication being deformity. So how do we do this? So this is the sort of a deformity. In the first stage, we do a posterior fixation where we put in the implants, and then we do a cantilever correction. We put in a straight rod, and when you put in a straight rod, there is a correction of the deformity. And in the second stage, we put in an anterior strut bone graft to reconstruct. So something like this, which is a deformity, we do posterior fixation in first, and then turn the patient and put in a bone graft. And when the bone graft fuses, this surgery has worked. So that's another one where we have opened posteriorly, and then anteriorly we put the bone graft, which is seen with the arrow. And that's another one, sort of a lower dorsal, where we run posterior fixation and then anterior bone graft. This is in a child where we use this sort of thing. So this patient had, in addition to deformity, this patient also had this internal gibbous. And because of that, there was cord compression. So this was corrected to this round back deformity, and then anteriorly we have done a bone graft. This is one at the sort of cervicodorsal junction. Again, it's a deformity with a dislocation where, as you can see, there is cord compression and all of that. And this deformity also had to be corrected by doing both posterior as well as anterior surgery, like for this patient. The second group are the healed kyphosis. So what we spoke of till now, these were the wet disease or the active kyphosis. So these are a little easier to treat because the disease itself is wet, and that makes the spine flexible. But the healed kyphosis, these are the difficult ones because they are extremely rigid and they are complex. They are not just one plane deformities, and they have this internal gibbous which threatens the cord. There's a high risk of neurological injury and used to be discouraged by most authors. In fact, the first article when we started this work, so we started this work with Dr. Lahiri in the sort of late 90s. The only paper was halo release and traction by Hong Kong. But what we started and now is done in the worldwide is the single stage spiral shortening osteotomy. or a vertebral wedge resection. So it's a posterior alone surgery. It is done only from the back, and we remove an apex of a wedge and a 3-column resection. So we do a 3-column resection and correct it. And in the order of severity, there are 3 surgeries. I'll show you the diagram wise. The first is known as the eggshell procedure or Heineck procedure, where what we do is through the pedicle you go and you decancellate the vertebral body. So you do this, you go in through the pedicle on both the sides and you decancellate, you pour out this vertebral body. And then you create a compression fracture with the implant. So we remove all of this and you do a compression fracture to create it. The next stage is a vertebral resection or a shortening osteotomy, where you excise the vertebra. So that is done like this. So this is a kyphosis. What we do is we put in the screws and this is excised. So you go from the sides by a transpedicular approach and you excise this entire vertebra in front of the spinal cord. And that is an osteotomy. And then after that, next we remove the posterior elements. So when all of this is removed, what happens is that the 2 columns are separated. The upper and the lower column is separated, actually fully separated like this. It is completely separated with only the spinal cord hanging in between. And then when it is corrected, when it is compressed, there is a shortening and correction and a wedge closure. For a larger magnitude deformity, the column is shortened but would cause cord buckling. So again, to show you here, this osteotomy is done, posterior osteotomy is done, and these 2 are separate. But when you start correcting, this is the spinal cord starts buckling. And if it buckles, this patient can get neurological deficit. In that case, one puts a small cage anteriorly and opens it over the cage. This is known as opening closing wedge osteotomy. So the correction is by shortening and straightening. So this patient with a 90-degree deformity, what we do is shortening and straightening and a wedge closure. That's another one which you do. We have done an osteotomy. So these are healed, completely healed diseases where we do an osteotomy, a wedge closure, and a correction. Another one, this is a 130-degree deformity with a huge internal gibbus. And this patient, we needed to do an osteotomy. We did a 90-degree osteotomy for this patient and corrected it quite a bit with very basic implants. And then this gap anteriorly, we had to put bone graft later on, because it's only when the anterior arthrodesis takes place that this has succeeded. There's another guy, again, healed disease, very bad dorsolumbar kyphosis with a lumbar hyperlordosis, 87 degrees, and treated again with osteotomy and correction. And as you can see, there's a significant correction. Another girl, this dorsolumbar junction is a very bad deformity because it gives rise to lumbar hyperlordosis. And plus this patient had early myelopathic signs. And this was again treated with an osteotomy and correction with a wedge closure. So this patient doesn't need anterior surgery, just done with the posterior surgery. This child we have already seen in the previous one. So the thing is that when you are doing these surgeries, there is a question of risk versus reward. So yes, there is a risk of neurological deficit, but the reward is a deformity correction. But the shortening osteotomy is better than the lengthening osteotomy. We do spinal cord monitoring and have a look. Lastly, coming to the another group of patients who have late onset paraplegia. So these patients have got a kyphosis and a deficit, but they have paraplegia. For these patients, we try to not correct the deformity. We just do an anterior decompression. Coming to another subtopic, which is C1, C2 COX, I just want to go over it. So C1, C2 COX, you will make sure you look at the X-rays properly for soft tissue, prevertebral shadows. They come with neck pain, torticollis. They often come supporting their neck. And if you do an X-ray, you'll see this kind of atlantoaxial dislocation. And these are usually treated conservatively. What happens is there's a destruction of the synovial joints and the ligamentous restraints, and therefore it causes an atlantoaxial dislocation. And what we need to do for them is we reduce them by traction, and we maintain them either by traction or a halo vest. And this can be treated. And if there is a severe dislocation which is not maintaining, then we may have to do a surgery to fix it as well. So this is another one which is very badly dislocated C1, C2. This is TB spine, very badly dislocated. Like you can see, this is here, this has gone completely back with basilar invagination. And so this patient is treated with surgery and an occipitocervical sort of fixation. So basically, we can do a C1, C2 fusion. So now, once we are looking at surgery for TB spine, you must understand what aspects of spinal function are affected by the disease. So it's very important to know what the disease is actually doing. And you need to know that some of these effects are temporary. So this patient may have a lot of pain and instability, but when the disease heals, this can stabilize. So it's not necessarily that they need surgery. And you need to know which of these aspects can be treated conservatively, like abscesses can be treated conservatively. But a bony gibbus cannot be treated conservatively. And you need to believe in AKT, because AKT is like magic. It will dry up the abscesses, soft tissue, there will be sclerosis, there will be fibrosis, and there will be healing. The only problem is that the speed of the action is poor. So this means that if you have a cord compression with a deficit, why we do surgery? It is not that the AKT can't get it better, but surgery gives them the best chance of early recovery, because the surgery is an immediate decompression. Whereas AKT is going to act slowly. It's going to take 6 to 8 weeks for it to get decompressed. And that's why we do surgery. And surgery is needed to take care of what AKT cannot achieve. That is the role of surgery in TB spine.
Fantastic, Dr. Darvi.
Yeah.
Phenomenal
So
cases.
one sec. Medical therapy is the mainstay of managing TB. You need to know the indications to intervene, and the decision is based more on clinical grounds than the MRI. This is very important, because the MRI overestimates, but the clinical grounds are what gives you your indication for surgery. And once decided to operate, to answer the previous question, you must be aggressive and do a best reconstruction and the best sort of decompression. Yeah. So I think that
Thank you. Very, very extensive, but very well covered. I am sure people will keep watching this again and again, because they'll get a link to this talk, and they'll keep watching again and again. Any questions now?
There are none in the chat box, but I had a couple of questions for sir. So in your practice, if you could give us a ballpark figure so we get an idea, as a spine surgeon, what percentage of cases or how many cases do you get referred who've been on AKT, not responding, and have turned out to be completely non-tuberculous? So we get an idea as to what the real world figures are.
Actually, because my figures would not be very applicable to community, because we are working in a tertiary care hospital. But what happens is, if you look at patients who are on dialysis, patients with renal failure, diabetics, and rheumatology patients, the incidence of non-tuberculous infection may be as high as 70 to 80%. So if a patient is, any patient which I get a reference from nephrology, more often than not turns out to be staph or E. coli or strep. So that's a
And
very,
in those
very
debridement?
No, they don't.
In
No,
those...
biopsy. No. See, the treatment is still based on clinical grounds. If the patient has only pain and a infection, and we do a biopsy and it is proven to be staph, in fact, the medical management works better in these patients, because it is faster than AKT, right? But if the patient comes with a deficit, then of course you have to debride them. So for the pyogenic also, the principle remains the same, knowing well that actually it is better. If you can grow an organism and get a culture, then your medical management is actually very quick.
I have a couple of questions.
Yeah.
Number one is whether decision for surgery depends on comorbidities. Like patient has diabetes, then whether you would tend to operate or you will not tend to operate. That is number one. Yeah, I think you can answer that, and then we go.
I think diabetes is not that, it will not be a factor one way or the other. I don't think it will be one way or the other, because it is not an indication that because he has diabetes we have to operate, and it is not a contraindication. If the diabetes is not, we control it and we have to operate. So diabetes would not be, but some other comorbid conditions like cardiac issues, etc., can be a contraindication to surgery. If it's a soft indication, I mean, see, like I said, in the indications also there is a whole spectrum of indications. To those which are completely hard indications and those which are little soft indications. So if there's a patient who I'm going to operate on because they have instability, pain, they're not getting better, and you have to mobilize them, and this patient has an ejection fraction of 15%, then I will say, no, you be in bed for longer, right? But at the same time, if there's a patient who's gone off his legs, is paraplegic, then the choice given to the patient is that do you want to be paraplegic for the rest of your life, or you want to take a chance? Still, life trumps. Like if his ejection fraction is 10%, I will still not do it. But at the same time, you have to then modify that indication.
I think Dr. Srinivas has raised his hand. Am I right, Srinivas? Can you unmute him? Dr. Menon, can you unmute Srinivas?
No, sir, I can't. I have logged in from a different side, but he's not raised his hand. I can't see his hand.
No, he had raised his hand.
Who do you want to unmute?
Dr. Srinikant Yadkikar.
Yeah. No, I cannot unmute him. We can ask to unmute, but we can't unmute.
Yeah.
Because he had raised his hand. Okay, then approximately what is the percentage of cases who need surgery in your experience?
So again, see, my answer will not be the community answer. I think in
Yes.
community, the community answer would be 5%.
Oh, that low.
My answer would be 15 to 20% because patients come to me for an opinion or come to me for surgery.
Correct. But as a ballpoint figure, about 5 to 10% need surgery and 80 to 90% are likely to settle with medicines. Right? Yeah. Great.
And would you start AKT immediately after taking the biopsy, or if the histopath, or what if the histopath is inconclusive, doesn't show granulomas, but clinico-radiologically you suspect tuberculosis?
Yeah,
and
I would start.
Culture would come at 3 weeks.
I will do the biopsy and start AKT from the next day. You can't wait. You can't wait for. There is no real reason because you can always stop AKT which you have started, but you don't want to miss the boat.
When would you do a CM guided biopsy?
Actually, I don't do it at all. I send every patient for the CT guided biopsy.
Okay.
I mean, you can do a CM guided biopsy in almost any case because I'm doing MIS surgery, so I'm putting screws also through CM, right? So technically I can do it, but the CT people is always better because CT gives you an axial cut, so you can see the tip of the needle as well. And I mean, honestly, it's a question of having time or not. I mean, if I had more time, I might do it, but I don't have time.
But there is no specific indication for a CM guided biopsy.
So there is no indication for CM versus CT. CT will always be superior at every single stage.
Okay.
CT will be definitely superior because in a CM guided biopsy, you are looking at 2D imaging to give you the effect of a 3D imaging. You use your orthopedic mind to know where the tip of the needle is. Whereas in a CT, it actually takes you there. You can see the tip of the needle. I think if you don't have a facility and all, then you may have to do it. Mofussil areas, you may have to do it.
Another thing is, we are talking of posterior fixation and you turn around and put a graft anteriorly. Yeah. As it is, you are going anteriorly. So why not do the entire surgery anterior?
See, that is because it depends on the amount of fixation which is needed. The anterior, you can't extend and put in long fixation. And it is the compression surface. So scientifically also, you put an implant on the tension surface and you put a reconstruction on the compression surface.
Okay.
Plus, it is a disease.
There was a time when only posterior instrumentation used to be done and no anterior surgery. So is there an indication for that?
No. Not at all. Because if you do that posterior instrumentation will fail. These patients get a lot of pain. Because anterior always heals by a little collapse. So if you do only that and don't touch the anterior lesion, these patients will get a lot of pain later on. And implants will fail.
Any more questions?
Sir, Sir, however, sir, by a posterior instrumentation approach itself, without approaching it from the anterior side, we can put a case from the posterior side. Sir.
Yeah. It was there in my talk, right?
Yes, sir.
It was there in my talk, transpedicular. So we do that now. Transpedicular decompression is done.
So that is only all posterior approach.
That is all done from the back. So it is an anterior approach done through a posterior approach. So we don't open the chest. We don't go anteriorly. We go from the back only.
So that is generally done only in thoracic spine or even lumbar spine?
It can be done everywhere.
But lumbar, you would prefer anterior approach?
No, it actually depends on how extensive it is. See, what happens is in lumbar, the lumbar roots are there, which you cannot sacrifice. In lumbar spine, the lumbar roots are there, which you cannot sacrifice. So, so often you need to go anteriorly there. Whereas in the thoracic, suppose it's mid dorsal, even you can sacrifice 1 or 2 nerve roots to get the access. It doesn't matter. I had cases as well. I mean, I'm not done in terms of that.
Yeah, we have 5 minutes, so maybe.
Yeah, it's up to you. I mean, if people are tired and they're fed up, then it's fine. But otherwise, I had cases as well. I can just go because we won't even interact. I'll just show the cases. Maybe there's a learning from each of these cases.
Yes, I think 5-7 minutes, please.
So because now we have already done the theory, so we can just start. So this is a 39-year-old female with biopsy proven COX, sensitive, but patient has, in spite of 4 months AKT, she still has these huge psoas abscesses and had severe pain and discomfort. So to answer that Ayesha's question as to whether whether abscesses need to be drained, this is a patient where the AKT has not worked in spite of being sensitive and it's causing pressure effects. So this is one where we drain. So this is drained with a retroperitoneoscopic approach. So through small incisions, we just do a retroperitoneoscopy and we are able to drain this. So this with the drainage and the AKT completely healed up and the scars are not even visible. So this is one way of doing it. This patient, 4 months of AKT. So initially came with this sort of very early lesion, but with 4 months of AKT, continued worsening, constitutional symptom worse, but no neurological deficit, significant destruction and abscess. So this is a patient where people may say that we can take this patient for surgery, but like I told you, we need to review the diagnosis, we need to see what is happening, and this patient, we did another biopsy, and in the biopsy, live bacilli were noted. So after 4 months, if they are live bacilli, it means that the drugs have not worked. So we started on second line AKT, and then the cultures then proved MDR. But then with MDR, this completely healed up with the second line AKT. So it didn't need surgery. On the contrary, there is this patient who was histologically proven TB, 3 months AKT, but progressive neurology and pain. So this patient was operated by this approach, which is the transpedicular approach, posterior fixation and anterior cage. This patient we have seen actually in the previous thing, but patient progressing with pain, deformity and neurology. And then this patient is taken up for surgery. This is another one, upper dorsal. You can see severe multi-level destruction with cord compression, signal changes extending all the way here, like a dense neurological deficit, a lot of disease. And this is the abscess which you can see. And this patient also treated with transpedicular decompression, posterior approach. So from one side, we go anteriorly and remove everything and put in a posterior cage. And as you can see in the post-op MRI, it's completely decompressed from here. Another one, again, biopsy proven sensitive disease, but 4 months AKT, 8 months AKT taken now, and 8 months AKT still there is like plenty of disease there, and there is a bit of compression, and MRI was getting much worse in this patient. So this patient again was operated. We did a posterior fixation and a transpedicular decompression, and then this patient got better. This is another patient, just to show you a young patient at this cervicodorsal junction with extensive disease and translation. We've seen this patient before, and this patient implants become the problem. So for this, we use this device, which is a heart shield, to do as well. This is a child now. Patient came, 11-year-old female, weakness in both legs, difficulty in walking, and neck pain, classic TB spine, but power reduced. So with deficit, and as you can see, this is quite a bad dorsolumbar junction lesion. So dorsolumbar junction is cervicodorsal junction. It's a very bad junction because these dislocate, etc., and they cause a lot of problems. And as you can see here, there's cord compression, and this goes into a very bad kyphosis at some stage. This patient also had a cervical lesion over here. So this patient I operated, and I left the cervical lesion alone to be treated in the collar. But because this patient had kyphosis, I did a posterior sort of decompression and fixation. I used some sublaminar wires as well and did a transpedicular decompression. And this patient also recovered completely, and the deformity is sort of improved. And another one, this is a 10-year-old female. So 10-year-old is very small. This patient had weakness in the upper limb, had a grade 0 power actually, and very, very weak upper limb, and the lower limbs are okay. But you can see that it was because of this and this cord compression and abscess. So you can see a big abscess. So with so much weakness, we had to operate this patient early. The only thing is this patient is 10 years old, so our normal implants wouldn't work. So there was a big. So I just put a very simple implant, just a I just managed to get this plate from the orthopedic department. I don't even know what it was, and put in one screw above and one below. But with a little protection, follow-up should have been there. This is the follow-up. Sorry, 6 months follow-up, and this has healed up. So there is no kyphosis, and this patient completely recovered. That's another one where this patient had a dorsolumbar junction issue, like upper lumbar, but dorsolumbar junction with collapse and with this sort of kyphosis. And this is just to show you all what happens. Now, this patient, I said this patient needs surgery. You're getting a kyphosis, you have a lot of problems, you're never going to get better. But this patient insisted on no surgery, took full AKT, and we followed up this patient over a period of time. She's healed up in this position. And she's got full function and no pain, and she didn't want surgery. So, but of course, this patient is something which you'll have to see in the long run as to what happens to her, because structurally her spine is not good. Just to show you that it's not necessarily that, even without surgery, patients do tend to get better. So I actually managed to finish these cases in 5 minutes, but I just went through them without discussion. So, yeah.
Yes, thanks a lot, Dr. Dalvi. A very, very extensive discussion and great cases. Thank you. I'm sure it must have been very stressful for you to talk for 2 hours. And I'm sorry for that. But thanks a lot. Thanks a lot. So friends, we are coming to the end of our fellowship. And it doesn't mean, as I said, end of friendship. So we'll keep communicating. We'll keep this group open. And you are most welcome to communicate, give inputs, ask questions, discuss cases. You're all most welcome. Dr. Menon, would you like to say something?
Yes. Thank you first to Dalvi sir for this extensive and very to the point talk. Like always, he's very precise and all slides are take home. So I think a lot of messages for the delegates. And thank you, Agashi sir, for this platform for all of us, where we could, Zoom and COVID has got all of us together sitting in different corners of the country. So that's one advantage which has come out of it. Thank you to all the delegates for participating, and we'll keep the group open, like sir said, and discuss cases. We'll share cases, you can share your cases and keep it open. So it's not just the end of communication. It stays open.
Okay, with that, bye-bye as of now, and hope to see you in person in near future. You can all unmute and let's have a bye-bye.
Thank you very much, sir. It was a wonderful fellowship, and it was very informative. It was highly illustrative, and it will definitely help us and guide us in our future course. Thank you very much, sir. And thank you very much to all the respected faculties and all my friends for teaching us and guiding us. Thank you very much.
Thank you.
Okay, friends. See you then. Bye-bye.
Okay, thank you.
Bye, sir.
Bye. Thank you, Dr.
Bye.
Devi. Bye-bye, Dr. Menon.
Bye, sir. Bye, sir.
Bye, sir.
Bye. Bye. Is Dr. Thakur there? No.
No, I think
Okay.
sir is not logged in.
Yeah. Okay, bye-bye.